Thank you very much, Peter. I forgot to say welcome to the President of International AIDS Society, Professor Linda Gail Becker. I was thrilled by my Secretary General to congratulate me on this IAS nomination, which I did not think that he will mention that in this meeting at all. So it's my honor to hear his congratulations here. Anyway, as Peter mentioned, this memorial talk, which is the fourth memorial lecture, should be given by David Cooper, my colleague or my co-director of HIV-NAT. But because of his health, he could not come. But anyway, for those of you, he told me to tell everyone that he is now healthy enough. Okay, but just he needs some more months to recover from that one. As a co-director, there's no way that I can escape for this memorial lecture. Okay, the first one was given by Professor I have by Julio Montaña. Okay, the first one. Okay, this is Professor Yup Lang and his partner, Jacqueline Van Tongeren. Both of them passed away on July the 17th during the Malaysian flight to Melbourne. In fact, I had a dinner appointment with Yup on July the 19th in Melbourne. Yup is a doctor, is a researcher, and activist. People will say ART is impossible in resource-limited countries until we need to be sure that all the randomized controlled trials will say early treatment is good enough. But Yup said, if we can get a Coca-Cola and beer to every part of the world, why not do the same thing with ART? He always said that clinical trials, double-blind trials is important, but you should not wait. It's a smart investment, as long as no harm created. It's unethical to allow new HIV infection to occur until the end of the randomized control trial. You have seen these pictures before in the past. Now, from 1998, the first Bangkok Symposium, up until 2012. Okay, my topic is how can we end HIV? Then let's talk about the meaning of ending HIV. Ending doesn't mean zero. However, it still gets along or goes along with the getting to zero, the UNS theme. The working definition of ending HIV is to turning HIV infection from an epidemic to endemic. That means only transmission between two people rather than transmission to public in general. If this is the case, then HIV is no longer a public health problem. This is what we want to see. It can be measured according to this criteria here. The ending HIV is the new infections in the year 2020, 2 years from now, should be less than 10% of those 10 years ago, i.e. the year 2010. Besides this zero or low new infections, zero death is also one of the getting to zero theme, and also zero stigma discrimination, which I said here. The last zero is more difficult to achieve. Then can we end HIV? Can we? Who are we? We, rich countries or poor countries or throughout the world? My remark here is the whole world should be able to end HIV. Each country may have different pace to end it, depending on the many things here, depending on the political will, depending on the hard work of the program implementers, resources, community participation, international collaboration, international sticks and candies, in order to move the progress along the way. So everyone, every sector needs to have a true commitment to end HIV, not just having a policy to end HIV. You need to be really committed and do it with a sense of urgency, not just business as usual. Because we all know that if we can end it faster, it's more cost saving. How can we end it? I said that this is my summary of all my talks today, or this half an hour here. It's a non-exclusive combination of early testing after risk behaviors, immediate ART, PrEP and PrEP for negatives who are at risk, and also enhance ongoing prevention strategies, including condom harm reduction. At the same time, stigma and discrimination should be minimized across the continuum of prevention and care. Let's talk about treatment, antiretroviral therapy. Antiretroviral therapy is nowadays very potent, safe, convenient. It benefits individuals to be healthy. It benefits community so that he or she will not transmit HIV to the others. Access nowadays is global or universal because of the cheaper price, because of the external funding from PEPFAR, from Global Fund. We all know that ART is cost effective. It's easy nowadays to treat HIV, single regimen, single recommendations. And we have means to follow the success of the treatment with the viral load, with the resistant testing. We also have second-line drugs, third-line drugs for those who fail the first line here. The objective of ART, or the ultimate goal of ART, is viral suppression. Viral suppression, or undetectable viral load. It may be less than 50 copies, it may be less than 40 copies. But the virus still be there, still in the body. We all know that up to 95% of those people who are on ART will have suppressed viral load by 6 or more months of ART. Once the viral load in the blood is suppressed, the viral load in the anogenital tract will also generally suppress. HIV transmission depends on the amount of virus in the transmitting fluid, either blood or genital secretions. Therefore, it has been proved that low or actually no sexual transmission once the viral load is well suppressed. As evidenced by HPTN-052, opposite studies and partner studies, for example. Evidence also exists for non-sexual transmission. I'm not talking about IDU, I'm just talking about preventing mother to child. Also, viral load in the mother at the time delivery also correlate with transmission here. So, in summary, with ART, we will achieve undetectable viral load. Undetectable viral load means untransmittable to the others. U equals to U. Let's talk a little bit about U equals to U. Undetectable is in fact untransmittable. In the zero-disconnect heterosexual couples, the HPTN-052, we heard about the story many years ago, but for 5 or 6 years of follow-up, with 10,000 couple years of follow-up, only 8 patients who were infected, for those who are under treatment, but they were all infected during the early phase that the index case was treated, or during the phase that the index case had viral load failure or treatment failure. For the partner study is heterosexual discordant couples. The index case was treated until undetectable viral load. They follow these people along, no even a single case of HIV infection. Even, more than 30,000 unprotected sex acts. For the homosexual discordant couples, the same thing happened for partner study with, again, 22,000 unprotected sex between the viral suppressed patient with uninfected persons. Again, no even single infection. The opposite attract study, Thailand is a part of that study, the same thing happened. No single infection. Once the index case is viral suppressed. Also, in the opposite attract study, they had 3 incident cases when they had sex with non-index case, anyone. So those people, then certainly they could be infected. But if they had sex with the index person who has been viral suppressed, never had any infection. So U equals to U is a very important message that we want to say, for treatment of infected patients. And also U equals to U is also a very good marker to reduce stigma and discrimination among general public. Because even sexual partners of the infected person don't get infected by the infected person, while general public will discriminate or stigmatize those infected people. I think it's U equal to U. It's a very good signal to reduce stigma and discrimination. Okay, so successful treatment will lead to undetectable viral load and high CD4 cell count. Once you have undetectable viral load, you have no infectious source to infect anyone else. So the first 90, no new infections. This is what happened, no new infection, the first 0. When you have high CD4, as a result of treatment, you will not have HIV-related morbidity and mortality. So again, no HIV death, the second 0. So the factors that will related to successful treatment, good drug, good doctor, good patient, good monitoring system, and also good system. Good system is more important than all the good drug doctors or whatever. For example, it has to be convenient for people to be treated. It should be free. No delay in referral or in starting ART, i.e. it should be rapid initiation of ART. It should be simple, easy access, for example, by differentiated service delivery, having committee people to distribute ARV obtained from the hospital, for example, so-called task shifting, no stigma and discrimination. However, we talk about ART. There are a lot of challenges of ART. Number one, you have to find someone to receive ART. Okay? Everyone knows nowadays HIV diagnosis is the most important prerequisite for HIV treatment. Once you know that you are HIV positive, linkage from the VCT center to the ART center is also another step of losing these people. Once even in the ART clinic, some doctors may not start ART immediately. They just wait, giving vitamin pills for 3 more months to see whether or not they adhere to the vitamin pills before they start ART. This is also another step of delaying ART initiations. Again, successful viral suppression for lifelong is also a challenge here. In this meeting, we will discuss in detail about same-day ART. Same-day ART is to prevent morbidity, mortality. The longer you wait, you may get tuberculosis or whatever. To prevent loss to follow-up. To prevent transmission to others. So the concept of same-day ART is we start ART the same day of HIV diagnosis without knowing the CD4 cell count, knowing any other laboratories. These laboratories will be drawn. If it's abnormal, we always call the patient to come back to do whatever necessary. except in two groups of people that we are afraid that they might get immunity activation syndrome, tuberculosis, cryptococcosis. So if we can identify or exclude these two conditions out, we can start same-day ART. If same-day ART is not feasible due to whatever reason, then the WHO recommendation of rapid ART within 7 days of HIV diagnosis should be the case. We talk about same-day ART, immediate ART. Early HIV diagnosis also adds to the value of immediate ART. Early HIV diagnosis means we should diagnose before these people will transmit HIV to many people. We should diagnose right away, rather than to wait until they get sick or until they transmit to many people. So that means you need to have HIV testing at frequent intervals. For example, in Thailand we said everyone can have 2 tests every year. That means every 6 months. Or it can be sooner than that. At least 3 months diagnosis, 6 months diagnosis, they will not transmit HIV to too many people. Or immediately means 7 days to about 4 weeks after risk act. In this case, you need to use a very sensitive assay. Using sensitive assay, then you need to be sure that you have a testing algorithms that the 4th generation positive, 3rd generation still negative, whether or not this person is really HIV positive. I think this is a very important aspect. Testing strategies targeted at high-risk population, for example, hormonal monitoring for transgender women is also something to get transgender people to come out for other health services as well as HIV testing. Key population-led HIV testing is also something that I will mention later, including self-testing, free HIV testing, and also same-day or even same-hour testing, rather than to wait for ask them to come back the next day for HIV result. Many of them will also lose to follow up here. So when we talk about key population-led health services, I like the word here. Nothing with us, without us. Nothing with us, without us. So we want to do something with key population. We need to involve the key population at the beginning. Nothing with us, without us. I think this is a very important phrase here. So what we do here in Thailand is we strengthen the capacity of the community key population group, in this case MSM and transgender, to the way that they have good knowledge of HIV, good knowledge of GCP, HIV testing from finger prick, how to provide or suggest PrEP, for example. So this is done by community people, lay people, together with the government hospital health professionals. So more or less a mentor to this group of people here. It has been done in 7 drop-in centers throughout Thailand, as you can see from the map here. Both MSM transgenders, male sex workers, transgender sex workers here. For the year 2016, more than 2,500 MSM being tested, which is about 40% of all MSM tested in Thailand by these 7 drop-in centers as compared to another 1,000 government hospitals. 40%. They could diagnose more than 400 cases of MSM and transgender in that year, which is about 30% of all HIV diagnosis among this population here. As you can see, the mean CD4 cell count was very high, 366, as compared to the median CD4 cell count in a general hospital where the people come in and diagnose is only 160. This is 366 here. And the link to care while a patient is also as good as in the hospital here. So in principle, test and treat should be able to end AIDS. Because you test them early, you treat them, and no one will be transmit HIV to others. However, in the real world, at first, 5 years ago, I thought test and treat is the answer to end HIV. But nowadays, we all know from all countries here, this is not possible. Because before they will come for the next testing cycle, they may already infected and they may already transmit HIV to many people here. That's why the introduction of PrEP comes to the stage. PrEP is highly needed for those tested negative on the same day that they are found negative, on the same day, not the next day. Okay. Just in this case here, the community key population-led health services that I mentioned to you, incidence among MSM in this cohort here, 6% among MSM, 12% among male sex workers in Pattaya. So the incidence is very, very high. That's why you need PrEP. Don't deny PrEP. You need PrEP. This is the PrEP program in Thailand here. It's a long development here, starting from having the PrEP in the Thai guideline in October 2014. December the same year, at the Thai Red Cross Anonymous Clinic, we started a fee-based PrEP services here, 30 baht or $1 a day, so-called PrEP 30. Then followed by many PrEP sub-study, as well as by Princess PrEP in January 2016, using Princess Somsavi funding for preventing mother-to-child, transfer it for preventing HIV transmission among MSM and transgender here. And then followed by many studies, including the PrEP program initiated by the Thai government, so-called PrEP to Start. I'm very glad to tell all you here, by the end of this year, PrEP should be included in the National Health Security Office system. That means everyone is getting free if they are MSM and transgenders with a high risk. So this is a great achievement of Thailand here. When you look at all the PrEP users in Thailand up to the end of last month, we had about more than 6,000 people on PrEP in Thailand. The majority of them is from fee-for-service PrEP, This from the Anonymous Clinic, as well as one of the private clinic on Silom Road. Altogether 4,000. And the Princess PrEP, the key population-led PrEP, another 1,700 cases on PrEP here. Just to tell you an example from Australia, they launched a statewide or countrywide scale of PrEP program here since March 2016. As you can see, for example, in the New South Wales states, rather than to have 3,700 cap for MSM and MSM people in New South Wales, right now they have more than 8,000 people, or more than 8,000 MSM on PrEP just in New South Wales itself. What they found out is interesting to see. More than almost half of reduction of new infections in the state of New South Wales, 31% for the overall MSM diagnosed last year, and also almost 57% decrease in the non-late. Non-late means from CD4 to 200 to 500 MSM in that country. It doesn't mean that the MSM in New South Wales, they have less, more condom use. No, they have the same condom use as before. Okay, my last few slides here. What needs to be done to end AIDS? We have to have proactive reaching, recruiting, and testing the key population, the right population, and at the right location. Very important message here. Hotspot mapping, peer outreach, mobile testing, key population-led health services of interest of KP, as I mentioned, hormone monitoring, anal pap smear, for example. And then you have to have rapid initiation of ART at anti-CD4 level. That means same-day ART. And retain them for viral suppression. PrEP for seronegative individuals who are at risk. And lifting all legal religious barriers, minimizing stigma and discrimination. Most important, you need to have strong political support from politicians, from healthcare providers, and also a demand creation, i.e. activism by key population as well by civil society. We can no longer be in silence, but we need solidarity. Last slide here. In conclusion, we can end it. If we cannot reach 90 by 2020, 2 years from now, we will lose momentum. And the chance to end AIDS by 2030 will be then slim. Therefore, the next couple of years are very important to turn off the epidemics. We have to do it fast, and we have to do it the right things now. Leadership is important, especially political leadership here. So my last tribute to Yup, Lang, and Jacqueline here. Thank you very much.